The liver is a powerhouse organ performing over 500 vital functions. One of its most important roles is drug metabolism, acting as the body's detoxification center. It filters the blood, removing toxins and processing medications, ensuring drugs are broken down into forms that can be safely eliminated. When medications are taken, they enter the bloodstream and are transported to the liver, where enzymes transform the drug into metabolites. These metabolites are often less active and more easily excreted by the body. The liver's ability to metabolize drugs is crucial for maintaining the right balance, ensuring medications are effective without reaching toxic levels. However, when the liver is damaged, its ability to perform these functions is compromised, affecting how medications work in the body. Liver failure presents unique challenges for medication management. The liver's impaired ability to metabolize drugs can alter both pharmacokinetics and pharmacodynamics. For healthcare providers, understanding these changes is crucial for ensuring the safe and effective use of medications in patients with liver failure. Dosage adjustments, medication choices, and close monitoring become even more critical in this vulnerable population. In liver failure, the gastrointestinal tract often becomes a less hospitable environment for drug absorption. The liver is responsible for producing bile, a fluid that aids in the digestion and absorption of fats. As liver function declines, bile production often decreases, impairing the absorption of fat-soluble drugs, vitamins A, D, E, and K, and certain antibiotics like rifampin rely on bile for optimal absorption. When bile production is compromised, the absorption of these medications can be unpredictable and incomplete, potentially reducing their effectiveness. The challenges to drug absorption in liver failure extend beyond bile production. Edema and ascites, common complications of liver failure, can interfere with the absorption of orally administered medications. The presence of edema in the gastrointestinal tract can create a physical barrier, making it more difficult for drugs to pass from the intestines into the bloodstream. Liver disease can disrupt the normal movement of the digestive system, with delayed gastric emptying often observed in patients with liver failure. This delay can significantly impact drug absorption, leading to drug degradation and reduced absorption when they eventually reach the small intestine. These physical changes hinder the journey of medications from the gut to the bloodstream. Once a drug enters the bloodstream, its journey is far from over. Plasma proteins, primarily albumin, act as carriers for many drugs, transporting them to their target tissues. In liver failure, the ability to produce albumin and other vital plasma proteins declines. This reduction in plasma proteins means a larger proportion of the drug remains unbound or free in the bloodstream, increasing free drug concentration. Only free drug molecules are pharmacologically active, meaning they can interact with their target receptors and exert their effects. The fluid dynamics of the body are dramatically altered in liver failure. Edema and ascites reflect the body's struggle to maintain fluid balance, impacting the distribution of drugs. For hydrophilic drugs, the expanded fluid volume creates a larger space for the drug to distribute, potentially reducing their effectiveness. Lipophilic drugs may accumulate in fatty tissues, leading to prolonged drug effects and an increased risk of toxicity. These fluid shifts can significantly impact the distribution of drugs. The liver's intricate network of blood vessels is essential for its functions, including drug metabolism and clearance. In liver failure, cirrhosis leads to scarring and structural changes, obstructing blood flow through the liver. This decrease in hepatic blood flow reduces the liver's ability to efficiently process and remove drugs from the bloodstream. Drugs that rely heavily on hepatic metabolism for their elimination are particularly susceptible to accumulation, increasing the risk of adverse effects. The cytochrome P450 system, or CYPs, are the workhorses of drug metabolism. In liver failure, the activity of these crucial enzymes is often significantly reduced. Drugs that rely heavily on CYPs for their breakdown are metabolized at a much slower rate, leading to higher drug concentrations and an increased risk of exceeding the therapeutic window. This necessitates careful dosage adjustments and close monitoring to prevent adverse effects. The liver acts as a gatekeeper for substances absorbed from the digestive tract, undergoing first-pass metabolism. In liver failure, this first-pass effect is often diminished, leading to higher than expected drug concentrations entering the bloodstream. This is particularly relevant for drugs that undergo extensive first-pass metabolism, such as propranolol and morphine. In liver failure, this first-pass effect is blunted, leading to higher drug levels in the bloodstream and an increased risk of adverse effects. Following phase 1 reactions, many drugs undergo phase 2 reactions involving the addition of molecules to the drug molecule. Glucuronidation, a crucial phase 2 pathway, makes drugs more water-soluble and readily excreted. In liver failure, phase 2 metabolism can be impaired, leading to slower drug clearance and an increased risk of drug accumulation. The enzymes responsible for these reactions may have reduced activity, further complicating drug elimination. The liver's primary route of excretion is the biliary system, carrying bile from the liver to the gallbladder and into the small intestine. In liver failure, the ability to produce and secrete bile declines, impairing the biliary excretion of drugs. This reduction in biliary flow can lead to the accumulation of drugs and metabolites that rely heavily on this pathway for elimination. Drugs like methotrexate and digoxin are primarily excreted unchanged in bile. In patients with liver failure, the reduced biliary clearance of these drugs can lead to significantly elevated drug levels in the bloodstream, increasing the risk of toxicity. The kidneys also play a vital role in eliminating drugs and their metabolites from the body. In liver failure, the kidneys often take on an even greater burden of drug elimination. Hepatorenal syndrome, a serious complication of liver disease, occurs when the kidneys begin to fail in the setting of advanced liver dysfunction. This decline in kidney function further complicates drug elimination, as both the liver and kidneys are now compromised. Monitoring kidney function through blood tests and urine output is crucial for guiding drug therapy and preventing drug toxicity. Drug half-life refers to the time it takes for the concentration of a drug in the bloodstream to decrease by half. In liver failure, the half-lives of many drugs are significantly prolonged, reflecting impaired metabolism and excretion pathways. This prolongation of drug half-life has important clinical implications, as drugs can accumulate to higher levels than intended. Lower doses or increased dosing intervals may be required to achieve therapeutic drug levels without causing toxicity. Close monitoring of drug levels can provide valuable insights into drug clearance and guide dosage optimization. Pharmacodynamic changes in liver failure influence how the body responds to drugs, and patients with liver failure may exhibit heightened sensitivity to certain medications, particularly those acting on the central nervous system. The blood-brain barrier can become more permeable in liver failure, allowing higher concentrations of CNS active drugs to reach the brain. Patients with liver failure may require significantly lower doses of these medications to achieve the desired therapeutic effect, while minimizing the risk of serious adverse events. Liver dysfunction can alter the expression, sensitivity, or function of drug receptors, leading to unpredictable drug responses. Patients with liver failure may exhibit an increased response to anticoagulants, medications that prevent blood clotting. This heightened sensitivity stems from the liver's impaired ability to produce clotting factors, essential proteins involved in the coagulation cascade. Close monitoring of coagulation parameters is crucial for adjusting anticoagulant doses and maintaining a safe therapeutic range. The liver is the body's detox center, breaking down harmful substances into less toxic forms. In liver failure, detoxification is compromised, leaving the body vulnerable to toxins. Accumulated drug metabolites can cause nausea, liver injury, and multi-organ failure. The central nervous system is highly susceptible to these toxic effects. Elevated ammonia levels in liver failure contribute to hepatic encephalopathy. As we've explored throughout this training, liver failure presents a unique set of challenges for medication management. This complex condition, characterized by the liver's diminished capacity to perform its vital functions, has profound implications for both the pharmacokinetics and pharmacodynamics of drugs. The liver, often referred to as the body's chemical processing plant, plays a central role in drug metabolism and elimination. It acts like a sophisticated filtering system, breaking down drugs into forms that can be more easily excreted. However, when the liver's function is compromised, this intricate process is disrupted, leading to a cascade of effects that can significantly alter the way drugs behave in the body. Understanding these alterations is paramount for healthcare providers entrusted with the care of patients with liver failure. Failing to recognize and address these changes can have serious consequences, increasing the risk of adverse drug reactions, drug toxicity, and even therapeutic failure. A proactive and individualized approach is essential in medication management for liver failure. Recognize each patient's unique liver function, medical history, and medication regimen. Conduct a comprehensive patient assessment. Review medical history, current medications, and liver function. Adjust dosages based on liver dysfunction severity. Start with lower doses and titrate slowly. Consider the drug's metabolic pathway and potential interactions opt for drugs with favourable profiles in liver failure. Close monitoring and patient education are crucial.